Hi, my name is Alana Haussmann. I am a fellow at UCLA, and here I will be showing you two different presentations of bullous lupus. So in our first case, we have a middle-aged woman who developed bullae on her arms and her torso. She went to the dermatologist. The dermatologist thought, this looks like bullous pemphigoid. And so as a result, because she was very miserable up front, she received Dupixent, she received steroids, both topical and oral. And unfortunately, after she had this visit, her disease really blossomed. It actually increased to cover about 80% of her body. She also had mucosal membranes involved, and so she was hospitalized. And in the hospital, she was treated very aggressively up front. There was a lot of a broad workup sent, including atypicals, including autoimmune panels, and she was treated with a combination of a mg per kg of steroids, IVIG, and she was actually given rituximab. As part of her workup, some serologies came back and it showed that she had a high positive ANA. Rheumatology got involved. When we met her, she had no signs or symptoms of lupus whatsoever, not in her past, not in her present. She had no medical history, actually. But her serologies were quite convincing that she could potentially have lupus because she had a high positive ANA of 1 to 640. She also had a high positive dsDNA. She had a high positive Smith. She also had DRVVT, and so we got our pathology results, which are not shown here, but essentially what we saw was both immunoglobulin and complement deposition at the basement membrane. And so we concluded by looking at her picture, by looking at the pathology, and by looking at her serologies that this was bullous lupus. And so as a result, in addition to all of the therapies she had, we added dapsone. And when she had dapsone, she really turned around. It was really amazing how quickly she improved. Unfortunately, a few days later, she developed some hypoxia. She also felt short of breaths, had nausea, and she was diagnosed with methemoglobinemia. So we switched the dapsone to colchicine, and she did really well. And then in the second case, we have a young woman, and she is from Africa, and she actually was diagnosed with bullous lupus outside of Africa. And what was striking about this case is that she came to us, and she was on a good dose of Cellcept, on high doses of steroids, on 20 milligrams, and she was on Plaquenil and also on dapsone, yet she still did not have control of her disease. She had bullae everywhere. And so what we did was we had to switch her management. We tried rituximab. She had an infusion reaction. We ultimately ended up with belimumab and methotrexate, and that is what got control of her disease, and her bullae got so much better. And so what I want you to take away from this is that bullous lupus is a rare disease, but it can actually present as a first manifestation of lupus. I want you to know that dupilumab can actually worsen bullous lupus, and we've seen this in the literature in addition to this case. What was also striking about this first case was that dapsone, even though it's a backbone of treatment for this disease, unfortunately it can be associated with methemoglobinemia, and we did see this in this case. And I also want you to know that bullous lupus can be life-threatening, and it often requires a multimodal approach, so think carefully and be flexible with treatment. Thank you so much.